Sam, I know you've done over 7,000 knee replacements, so you really are the man to ask. So talk to us about when a patient comes into you, how do you find out whether a patient needs a knee replacement?
Well, I think the key is firstly, you need to get to know the patient. You need to listen to them and let them talk to you about their journey. Very often, they've had symptoms on and off for many years, they've been managing, they might have tried lots of different therapeutic options, um, and they will tell you how their knee journey and their knee story impacts on their life. Um, as in everything in medicine, uh, the way you make a diagnosis is to take a thorough history, a careful clinical examination, and then special investigations. And in my world, special investigations are really a series of four X-rays and MRI scans. Occasionally, we need CT scans, and ultrasound scans can sometimes be necessary, but mainly it's X-rays and
Can
MRIs.
I ask you, Sam, because most people that are watching that, if they've been to see their GP or seen another consultant, they often would just get one X-ray or two views of an X-ray. So can I just pick you up on there in terms of the four views? Because that's obviously something that you're quite specific about. Can you talk us through why you do that and what views you would use?
Yes, so a lot of people around, certainly around the United Kingdom, might only have a front-on view called an AP view and a side-on view called lateral, and they are two standard views. But knee surgeons also like two other views. That is, one is a skyline view of the patella, where you have a bent knee and you're looking at the kneecap and how that sits within the system. And finally, something called a Rosenberg or Schuss view, which looks like you are skiing. Your knee is slightly bent, and you take that. And the reason
Is
why
that is that weight bearing view?
it's a weight bearing
Yeah.
view, so the AP is normally weight
Yeah.
bearing, but the Schuss view is not only weight bearing, but with the knee slightly bent. And that unmasks certain subtle signs of osteoarthritis. So, largely, when somebody has a worn out knee, they have three patterns of arthritis they will present with. The first is 60 out of 100 will present with the bow legged deformity. Medial osteoarthritis, inner compartment has worn out.
So that's when somebody comes towards you and you can see they're slightly bow leg, which we call varus, don't we?
That's right.
But they're putting the pressure onto the inside of the joint.
That's right. And that pattern is a very painful pattern. And the patient normally comes early because they can't walk or it's painful walking. The slightly more subtle variety is the valgus knee, that is the knock-kneed variety. And this is where it is a disease of the flexor surface of the knee joint. So this is a right knee. The medial compartment is the varus knee pattern, but the valgus knee is the outer compartment. And there, the disease is on the flexor surface of the knee joint. So when you do a standing AP view, you often see a really well-maintained joint space. But the Rosenberg view or the Schuss view will show that the bone is touching
At the front.
on the side.
On the side,
On the
right.
side. And often that patient will present initially with instability rather than pain, where you go from decent cartilage to clunk into the divot. And then only later on will they present with pain all the time. So
Because it's not uncommon that you get a patient that will see the GP and they've had a couple of views. They're in a lot of pain,
Yes.
but actually they say, well, my GP said it was only mild to moderate arthritis.
that's right. And so the Rosenberg view unmasks that. And it's not uncommon to see a lovely looking AP with well presented gaps and then bone on the Rosenberg. And then the final bit is, of course, the skyline.
Yeah.
Because 20 out of 100 people have kneecap osteoarthritis. And they're the people who can walk 100 miles on the flat, but getting out of a low chair or going downstairs or sitting in a car for long periods of time will hurt. And so that unmasks the kneecap variety. So if you get these four X-rays, you can then basically work out the wear pattern in the knee, and you can then start advising patients.
Because, if you think about, x-rays, they always say that should be your first investigation. But obviously with MRIs becoming more accessible, now you can self-refer for an MRI. I'm not sure how good they always are, but although I'm sure you do use lots of MRIs, do you think maybe there's actually too much focus towards MRIs when it talks about degenerative joints?
I have a practice where people travel a long way to come and see me, and so I like to cut down the toing and froing.
Yeah.
And so we, particularly in London, do what's called a one-stop service, where I have a master radiologist working in parallel with me, and we often X-ray and MRI before seeing the patient, because the patient will often come and say, why does it hurt in a specific place? And that's not always primarily because of the wear. It's often where the fluid is leaking. That's called a leaking Baker's cyst, or where the debris is, or where something is impinging around an arthritic knee. So I find if I have both the soft tissue view from the MRI scan and the bony view from the X-ray, I can answer all of the patient's questions on why their symptoms are so. And we can also then plan. And it's just really saving time and stopping patients coming and going all the time.